Alrighty. My name is Kendrick. I'm a senior undergraduate student here at Texas Tech University studying with the College of Human Sciences. I just wanted to take a moment to say thank you for coming out to view my presentation today regarding inadequate nutrient intakes in low-income women from the Copperbelt region in Zambia. This presentation has been developed in part with data from Upusana Mukherjee, a PhD student, and Professor Rona Oldawage from the College of Human Sciences Department of Nutritional Sciences. One of the main risk factors for the development of non-communicable diseases is micronutrient deficiencies. Due to a combination of both economic and social factors, women in developing countries are at a higher risk of food insecurity and developing poor health than men. Working with these populations to understand dietary diversity presents a unique opportunity to understand the dietary issues faced by a particular community. This understanding is fundamental in the development of nutrition interventions and educational materials that can be used to raise the nutritional status of these higher-risk communities. In order to track this, the Minimum Dietary Diversity Score for Women, or MDDW, was used and correlated with actual dietary intakes as measured by 24-hour recall. So some background on the MDDW. The MDDW employs the use of the Dietary Diversity Score, or DDS, which is a qualitative measure of food consumption that reflects household access to a variety of foods and is also a proxy for nutrient adequacy of the diet of individuals. The DDS questionnaire presents a rapid, user-friendly, and easily administered low-cost assessment tool. This indicator employs a set of 10 categories in which foods are classified and sorted into. An adequate DDS is 5 or above. This indicator system is used as a manner of evaluating nutrient intakes on a group level and is tailored towards women who often have distinct nutritional needs. So the purpose of this cross-sectional study was to examine the dietary intakes and diversity of low-income women in the Copperbelt region of Zambia. This study formed part of a larger PhD project in which 147 women residing in Zambia were recruited for data collection. In January of 2018, trained field workers collected 24-hour dietary recall and dietary diversity questionnaires in one-on-one interviews. And the nutritionists collected height and weight measurements, which were used to calculate BMI based upon the WHO classifications. The dietary diversity data were not reported in the PhD dissertation, and all of the data capturing, cleaning, and analyses were my responsibility. I used SPSS version 26.0 to generate the mean dietary diversity score and individual food group diversity scores. These scores were correlated with the actual nutrient intakes of 147 participants, which were measured by 24-hour recall questionnaires and then analyzed in the Food Finder analysis program, which was based on the South African food composition tables, as unfortunately no Zambian food composition tables exist. All of the participants in this study were low-income Black women with a mean age of 58 years with a standard deviation of 10 years. 86% of the participants were living under the national poverty line of Zambia. The participants consumed a diet with an energy intake of 73%, 12%, and 14% respectively from carbohydrates, proteins, and fats. This indicated high intakes of carbohydrates, marginal protein, and low-fat intakes, as a balanced diet should provide 45 to 65% carbohydrates, 25 to 35% fats, and 10 to 30% protein. Only 10.2% of the respondents had adequate dietary diversity scores, which was reflected in the poor mean dietary diversity score of 2.98 and the standard deviation of 1.06, with once again 5 being considered adequate by that indicator. So if we move over to the graphics, the BMI composition of participants, the majority of participants in this study were classified as overweight or obese, as 37% were overweight and 40% were obese. This is interesting considering the participants are all low income, and according to the 24-hour recall data, 100% of the participants had an inadequate overall energy intake in terms of kilocalories. So interestingly, while only 21% of the participants are of a normal BMI classification and 2% are actually underweight, the majority of participants are overweight despite consuming an overall adequate diet in terms of total energy, protein, and fat. This highlights a sort of paradox that exists between poverty and overnutrition, wherein people have inadequate nutrient intakes but are nonetheless overweight and obese. If we move over to the nutrient intakes, this table includes the intakes of several key macro and micronutrients of the participants. The participants' intakes, which are listed by medians and the interquartile frequency, or IQF, are based off the 24-hour dietary recalls and then compared to the dietary reference intakes. Although only one 24-hour recall was measured, poor dietary intakes were observed as 100% of the participants had an inadequate intake in terms of kilocalories. This indicates that they lack a diet fulfilling their needs of macronutrients, which is reinforced by 88.2% of the participants having an inadequate intake of protein. This may be associated with meat and other protein sources being a high-cost item for low-income persons, and this inadequate intake is reflected in 80.4% of participants being deficient in vitamin B12, which is an essential micronutrient only found in animal products. A diet deficient in animal products also puts the participants at risk for vitamin D and calcium deficiencies, with 98% of the participants being deficient in vitamin D and 86.9% being deficient in calcium. This presents a major challenge. Additionally, participants have a noticeably inadequate intake of both vitamin C with an 86.9% rate of inadequacy and vitamin A with a 96.1% rate of inadequacy. These deficiencies are seen despite the majority of the participants having an adequate intake of carbohydrates. However, with the majority of the participants deriving their carbohydrates from their staple food, which is a maize meal porridge, the participants lack a diet rich enough in fruits and vegetables to actually derive an adequate intake of either vitamin C or A. Moving over, the significant correlations of dietary diversity score with nutrient intakes indicate that intakes such as calcium, vitamin C, total protein, and all the other ones listed here clearly show that dietary diversity score is associated with higher nutrient intakes. This finding confirms that dietary diversity is important as reflected in many food-based dietary guidelines that promote the eating of a variety of foods. The results of this study highlight many of the challenges associated with a diet lacking in a variety of foods. Despite all the participants consuming an inadequate amount of calories, the vast majority of the participants were either overweight or obese. This highlights a paradox between poverty with food insecurity and overnutrition. The association between these two factors may be characterized by people in poverty not having access to healthy, fresh foods, and a tendency of these people to then consume more highly processed, energy-dense foods that lack micronutrients. Significant correlations between the mean dietary diversity score and nutrient intakes indicate that the consumption of a more diverse diet is associated with a more diverse intake of both macro and micronutrients. Low dietary diversity scores in this study were reflected by high rates of inadequate intakes of both macronutrients and several essential micronutrients. Notably, deficiencies in vitamin D and calcium, which are considered crucial for postmenopausal women in light of their already increased risk for the development of osteoporosis. In lieu of the results of this study, we recommend interventions such as nutrition education informed by behavior change models and designed to promote the consumption of a balanced diet rich in a variety of foods and thus nutrients. The results of this study indicate the necessity to understand and evaluate the breadth of inadequate nutrient intakes that exist in impoverished countries in both Africa and throughout the rest of the world. Understanding these issues lays a foundation for community nutritionists to develop programs and educational materials that can be tailor-made to specifically suit the needs of a community being studied based upon the challenges they face. The development of nutrition program based on this understanding improves the ability of nutritionists and community leaders to effectively combat and progressively eradicate malnutrition associated with poor dietary diversity and intakes. Thank you.